Good evening, everybody, and welcome to the webinar, Current Challenges and Strategies and Head and Neck Surgical Clinical Trials, Advancements in Treatment Strategies. My name is Anna Poe. I'm a head and neck surgical oncologist at Oxford Health System in New Orleans, and my co-moderator is Barry Winnick, who is head and neck oncology at the University of Illinois. I think we've got some great panelists this evening, and I'm going to go ahead and introduce them. We have Dr. Brian Bell, who's radiation oncologist, medical director of the head and neck program at Providence Cancer Center. Sid Param, head and neck oncology, Washington University. Stephen Lai, head and neck oncology, MD Anderson Cancer Center. Robert Ferris, head and neck oncology, UPMC, is director of the Hillman Cancer Center. And Tricia Wise-Draper, who's medical oncology at the University of Cincinnati. I'd like to go through a few ground rules to start. As we mentioned earlier, each speaker will have 8 minutes and 2 questions from the audience following each presentation. If there are questions that you want to ask, hopefully we'll have time at the end, and if not, you can directly contact the speaker. But hopefully we'll have enough time for all of your questions.
I'm Barry Winnick, and I wanted to welcome you all, as Anna did just a moment ago. For those of you who are not involved in the AHNS or want to become involved in the AHNS, the information is available to you right here. Additionally, next summer is the AHNS 11th International Conference on Head and Neck Cancer, which is going to be held in Montreal. We would encourage everyone, or as many people as possible, to join in. So I think right now we're going to start off with Dr. Ferris. He's going to be talking about neoadjuvant immunotherapy strategies in head and neck squamous cell carcinoma.
Thank you very much, Barry and Anna. It's a pleasure to be invited to participate with your esteemed group, and my assignment is to lay out the concept of neoadjuvant or window of opportunity platform to develop novel therapies and potentially adapt treatment intensity using a biologic intervention in the preoperative phase. Here are my disclosures. And just to remind everybody that the most simplistic patient stratification we're all now well accustomed to in terms of prognostic impact, and this we can determine at baseline. But most other patient stratification is dynamic, and the neoadjuvant window provides the ability to perturb the system, the patient and the tumor microenvironment, to really take this kind of stratification, which is so impactful in our decision-making, and move it forward to design unique therapies. And so my lab is based on immunology and the tumor microenvironment. And so we've asked for 20 plus years, can we modulate the immune microenvironment and optimize therapeutic targeting? We began back in 2008, a year or two after cetuximab was FDA approved. And I used to try to develop immunotherapies and get them to work. And then I realized it was smarter to take things that already worked and try to figure out how. And so we took cetuximab and said, well, let's harness the role of a surgeon where we can get tissue pre and post a relatively short window of cetuximab monotherapy, and compare pre and post biopsies and segregate them by response. You can do that with anatomic or functional metabolic type imaging, and you can see a responder on the left and a non-responder on the right. The savvy viewer will notice that the left is an HPV negative maxillary sinus carcinoma, and on the right is a typical oropharynx cancer. And so we now know cetuximab is less effective in HPV positive cancers. Nonetheless, this gave us the ability to segregate biomarkers using a neoadjuvant window. And in this example, we asked whether there were specific immune responses that we could compare the same patient with her or himself. That adds substantially the statistical power, according to our biostatisticians, than a cross-sectional study, because one person serves as their own control. And then we perturb the system and ask if you can induce, in this case, T cells against the epidermal growth factor receptor when you target EGFR with cetuximab. And indeed, we could show an inverse correlation between the induction of an immune response and the change in tumor size or some sort of clinical endpoint in the responder status. More recently, we've gotten a bit fancier and looked at T cell receptors, so you can get pretty sophisticated with transcriptional sequencing as well as genomics, looking at the actual antigen specificity. And this is just an example of a collaboration we have with a faculty member here at the Cancer Center. So obviously, since the Nobel Prize and before, many of us were focused on immune checkpoints. And kind of like cetuximab, you have an antibody that targets a relatively frequent expression like PD-1 or another marker, and yet most patients don't respond. And so could we use the neoadjuvant window as another platform to ask why there is a heterogeneity in response? We know here that it's better than other standard of care, but most patients don't benefit. And running a long phase 3 trial over the course of a year or two is not very efficient for patients or for the field of oncology. And so I think head and neck surgeons can apply a neoadjuvant window trial to take this sort of therapy. And here we did this and published about a year ago, just 2 doses of an anti-PD-1 antibody, nivolumab, which is approved along with pembrolizumab, and others like Ravi Belluri and Joe Curry and the group at Thomas Jefferson have put immunotherapies into this preoperative phase. The pre-treatment and the on-treatment biopsy is really the key, and of course, segregating by response that can be either radiographic or pathologic, and there's a little controversy there we can discuss. Here's an example where we enrolled both HPV positive and HPV negative patients. You can see a relatively similar 15 to 20% response rate using typical RECIST criteria. This is pathologic response, and you can see looking to the right of this so-called waterfall plot, the subset that respond, and it's really a short time point of a month. So there's information even in the more modest tumor reduction or responses. The obligatory CAT scan showing a tumor shrinking, as well as the pathologic response that our pathologists use of lymphocyte infiltration and keratin pearls of dying tumor cells. Now, our previous fellow, Marco Mascarella, working with Uma Duveri, and Marco's back in Montreal on the faculty, looked at what is the impact of a strong partial response or potentially complete response that we scored as downstaging between the pre and the post-treatment. And there's a very strong disease-free and overall survival. And so we may actually be able to begin on trial in a safe, monitored setting, modifying the surgical procedure, which is kind of a recurring question if you get a responder in the neoadjuvant window. And again, showing you the progression here of a trial that is now funded on Project 3 of our Head and Neck Spore renewal is a 3-arm trial of PD-1 monotherapy. We have a number of reports already out there, but we wanted an internal control group, and then adding on different combinations of nivolumab plus ipilimumab, which targets CTLA-4, or nivolumab and relatlimab, which targets LAG-3 in that lower arm. And in addition to traditional CT scans and pathologic response, this trial is a little more than halfway done. We're using a profiling of the entire tumor microenvironment that allows us to analyze single cells from a fresh tumor suspension. I think only a surgical surgeon scientist kind of a group, as we have here on this webinar, could do these type of trials and be able to move into these paired pre and post specimens. You can see how complex the different cell types are within the tumor microenvironment and how we can segregate them with these dimensionality reduction techniques like UMAP and Tisney plots. Then you can see how the peripheral blood and the tumor segregate in the lower left, and the HPV positive and negative. And so the power of this allows us to really look for populations and markers that emerge in responders versus non-responders. And so just to tie this up from Pittsburgh, this has been a sort of longitudinal approach where we start with a neoadjuvant trial, try to learn resistance markers, and then use that information to go back to the definitive setting and design prospective trials, usually in the early phase, where we can move therapy forward for locally advanced disease. And I just want to point out that this is not just a boutique kind of thing that happens at individual centers. Merck actually is running a large national trial of neoadjuvant therapy with pembrolizumab monotherapy for 4 to 6 weeks called Keynote 689. This is ongoing. You can see Ravi Upaluri and Doug Atkins were key in getting this going, and it's currently enrolling. And then the last thing I want to point out is that it's not restricted to preoperative. Here's an example where we know concurrent PD-1 plus chemoradiation is not all that effective. And we had a sequential effort, as you can see in the upper arm. And we put, as you see on the bottom, an on-treatment biopsy so we can measure pre-treatment and on-treatment, again, with detailed biomarker studies to try to figure out how these combinations are impacting the microenvironment and try to get an earlier signal before we wait and find out that a regimen doesn't work. So immune checkpoint therapy is effective, but we don't really know how to use combinations, and resistance is probably heterogeneous and needs to be personalized, and we think neoadjuvant and on-treatment microenvironment analyses are crucial. Thank you very much, and I'll turn it back to the panel and our chairs.
So Bob, thank you very much. For the audience, Dr. Curry is moderating and monitoring the chat room. So please send in your questions, and hopefully we can get some good ones, and Dr. Ferris can answer them.
I don't see any yet, but I'll steal the opportunity if that's okay. So do you think that we are at a point where we're likely to identify a way to bioselect these people yet? Or do you think we're going to have to continue sort of the reverse translation of starting with the trial and going backwards to identify people? I guess I'm asking if you have any leads yet that you'd be willing to share.
Well, I do think we're at the stage where there's enough data. I will tell you, and the trial I just showed, we're closing down the monotherapy arm in part because there's sufficient data out there, and we probably put 13 or 14 on it for comparison. But our surgeons here, Uma Devuri, Steve Kim, Mark Kubik, Sean Shudaran, Melanie Nance, are less enthusiastic when their patients get randomized to the monotherapy. Relatively modest benefits. The combos, on the other hand, I get a text at the end of their case and they say, wow, there's not much tumor left. And, you know, I had a 33-year-old fellow who was looking at a total glossectomy and ended up with, you know, a forearm partial glossectomy. And it really should only be done on the prospective trial and develop parameters for how to use the information and keep it safe for the patients.
What's your best bet? Do you think a few doses of neoadjuvant will allow us to eliminate adjuvant?
I think a lot depends on the response. Obviously, be interested in other folks on the call, but if you have a surgical specimen that is a greater than 90% dramatic response or potentially pathologic complete response, which frankly they see pretty commonly in lung cancer on the order of 20 to 25%, I think there would be a subset there where we could dramatically reduce adjuvant therapy and perhaps on trial consider observing.
Thank you.
So you don't see any other questions coming in, Joe?
Not yet. I don't know if Monia maybe, but I don't have anything in the chat right now.
Okay, well, we'll reserve some time at the end if there are some questions for specific speakers. So what we'll do is next is move on to novel strategies in radiotherapy. Dr. Brian Bell and Dr. Tricia Wise-Draper are going to be each discussing this. There's going to be some differences and there's going to be some similarities. And that's why we asked two speakers to speak on the same generic topic. So we'll turn it over to Brian first.
How's that? There we go. Okay, thanks everybody. Thanks Joe and the committee for the kind invitation to contribute to this esteemed panel. My charge today, and by the way, I'm a surgeon, I'm not a radiation oncologist, and as such, I'm not necessarily trying to put myself out of a job, but I am interested in making my surgery much more effective for our patients. So that's what I'm going to talk about, our work in terms of integrating immunoradiotherapy strategies in the neoadjuvant setting. These are my disclosures. And most of us are beginning to realize that immunocompetence is critical to local control with both surgery and radiation therapy. There's an evolving data set now in both the preclinical and clinical setting that not only is local control CD8 dependent, but also that immunosuppressed patients are substantially have a substantially worse prognosis than immunocompetent patients. We begin to see, as immunotherapy has been integrated into the definitive setting, we've now begun to appreciate that the sequencing and the timing of immunotherapy and radiation therapy may be critically important. And this has been highlighted, I think, with 3 now very high-profile clinical trials in the definitive setting that combined standard fractionated radiation therapy in combination with either immunotherapy or and in various combinations. So the Javelin trial, of course, was highly publicized earlier this year, avelumab plus chemoradiotherapy versus chemoradiotherapy alone, a negative trial. Recently at ESMO, Keynote 412, again, this is pembrolizumab in combination with standard fractionated radiation and chemotherapy compared to chemoradiation therapy alone, a negative trial. And recently, I think just yesterday, in fact, AHN004, the results of durvalumab plus standard fractionation radiation therapy versus cetuximab RT, again, a negative trial. And so it is clear that standard fractionated radiation plus immunotherapy, it doesn't appear to be effective in head and neck cancer. But this may have been predicted based upon an evolving data set in the preclinical setting that suggests hypofractionated radiation therapy may actually be synergistic. And we've become interested in studying this in the clinic based upon a couple of different synergies. The first synergy is that radiation can function as an in situ vaccine and enhance immune control of distant disease, or the so-called abscopal response. This is proven at least elusive in human patients, but our interest has been in a second synergy, which is that radiation induces changes in the tumor microenvironment and the surviving cancer cells that can result in immune-mediated local clearance of residual disease. So immunogenic modulation that might improve local control following surgery. And this is particularly important, as all of us know, in HPV negative squamous cell carcinoma of the head and neck. Mark Crittenden and Michael Goff from our institute, as well as others, have shown this through this occurs through a few different mechanisms. First is that radiation recruits activated effector cells within the tumor. Radiation upregulates FAS and ICAM and NKG2DL, as well as MHC1 on tumor cells. And however, radiation can also upregulate PD-L1 on the tumor, blunting NK and CD8 T cell responses. They've shown, as well as of others, in preclinical models, substantial improvements in local control, again, with high dose or hypofractionated radiation therapy in combination with checkpoint inhibitors. So armed with this information, we took this to the clinic and performed a phase 1b clinical trial that tested hypofractionated radiation therapy in combination with nivolumab, the PD-1 inhibitor nivolumab, in both HPV positive and HPV negative patients. We enrolled 4 cohorts of head and neck cancer patients prior to surgery. Each cohort was treated with hypofractionated radiation, or SBRT, either 8 gray times 5 or 8 gray times 3. Initially, this was a safety study, and we compared 8 gray times 5 to 8 gray times 3. We then picked the winner and rolled a 3rd cohort for comparative reasons of 8 gray times 3 alone without nivolumab prior to surgery, and then a 4th cohort of 8 patients with HPV negative. So again, patients received 8 gray times 3 Monday, Wednesday, Friday dosing in combination with nivolumab 6 weeks prior to definitive surgery. We planned the trial for all patients to receive risk-adapted adjuvant therapy as indicated. So pathologically risk-adapted adjuvant therapy, if there was no tumor or if there was not an indication for adjuvant therapy, then adjuvant therapy was not given, except for nivolumab. But we would omit radiation or chemoradiation if the pathology dictated. Our primary endpoints were safety. Our secondary endpoints were rate of downstaging following neoadjuvant therapy, as well as clinical resist response and pathologic response, specifically complete pathologic response and major pathologic response defined as less than 10% viable tumor cells in the specimen. So this kind of outlines the approach. The other important thing to remember is this is 8 gray times 3 to gross tumor volume only. So these were not wide radiation fields. These were delivered only to gross tumor volume. So if there was no metastatic disease in the neck did not get any radiation therapy, and only gross tumor volume was treated. Following radiation and immunotherapy, or following radiation rather, patients received a post-RT biopsy for correlatives, and then of course the resection specimen at the time of surgery. So from a safety standpoint, there was our primary endpoint was a delay to surgery. No patients had a delay to surgery. Not surprisingly, the first cohort of 8 gray times 5 was rather toxic. It was painful, and most of the toxicities were related to prolonged opioid use. However, 8 gray times 3 was very well tolerated. There were no grade 3 or grade 4 toxicities. Similarly, and this is where the rubber meets the road, while resist response did not necessarily correlate with pathologic response, our pathologic response was profound. All of the patients in this study except one, so 20 out of 21 achieved major pathologic response, and there was and all patients except one were able to forego adjuvant therapy. In the HPV positive cohorts 1 and 2 that received immunoradiotherapy, 100% of them had major pathologic response. In the HPV negative cohort that received immunoradiotherapy, 3 out of 5 of those patients, or 60%, generated a major pathologic response. Our complete path response rate for the entire cohort was 67%, major pathologic response 86%, and 90% of patients in this study were downstaged. And again, only 1 out of 20 received adjuvant therapy. So this is just another slide that illustrates how we were also able to either decrease the amount of surgery or again, eliminate adjuvant therapy. So again, treatment to gross tumor volume only, and in only one patient did the pathologic responses dictate adjuvant therapy, and that was a patient who underwent essentially a total glossectomy that had viable tumor, a positive margin, and that patient died about a year later. A couple of caveats from our experience so far that I think are important. One is because obviously we're not radiating wide fields, and we're certainly not radiating bilaterally. We want to ensure that any suspicious lymph nodes are interrogated pathologically. So we biopsy any suspicious lymph nodes, particularly even on the contralateral side. So in this case, just mild enhancement. This particular case was a negative biopsy. The other caveat, of course, is that we do see a relatively high rate of pseudoprogression. So the post radioimmunotherapy CT scans often suggest progression when in fact clinically and pathologically there may be no tumor. And the patient or the CT scan you see on the right-hand side of the screen, which suggests tumor progression, was actually a complete pathologic response. So the other important correlative findings, some of which are ongoing, but it's clear that NERTS minimizes lymphopenia, and this is probably a chemotherapy effect, but we're also looking at transcriptional differences between the baseline biopsies and immunoradiotherapy. And in general, these post-radiation samples are characterized by phagocytic and macrophage activation pathways and a loss of cell proliferation pathways. Interestingly, by surgery, many of these B-cell pathways are showing up strongly and associated more with the group treated with nivolumab. So in the wake of this study, we've entered a nice collaboration with our colleagues at UCSD, Silvio Gutkind and Joe Califano, and recently published this really compelling paper, and I'd encourage all of you to read this if you haven't. Robert Sadawi performed an elegant series of preclinical experiments in which he mapped beautifully and surgically interrogated the lymph nodes, the draining lymph nodes in these mice, all of which were treated with neoadjuvant immunotherapy with or without neck dissection, and amongst other things found that the presence or an intact lymphatic drainage system was absolutely necessary for effective immune-mediated control in these tumor-bearing mice. So based upon all of these favorable findings, we initiated a phase 2 clinical trial. Joe and I are leading this, that will test 8 gray times 3 on a Monday, Wednesday, Friday dose in combination with pembrolizumab prior to surgery in only HPV negative patients. Our aim here is to determine pathologic and clinical response, overall survival, disease-free survival, baseline quality of life indices, and then also from a correlative standpoint, determining whether NERT enhances T-cell infiltration into the primary tumor, whether it increases the frequency of shared T-cell clones, as well as germinal centers in the sentinel lymph node compared to a non-sentinel lymph node. So all patients in this study will also undergo sentinel lymph node biopsy or sentinel lymph node assisted neck dissection. So we'll have some interesting data from this study. So in summary, neoadjuvant PD-1 blockade plus SBRT 8 gray times 3 results in a high rate of major pathologic response in both locally advanced HPV positive and HPV negative cancer patients. Preservation of the lymph nodes appears to be important prior to immunotherapy and radiation therapy. Neoadjuvant immunoradiotherapy may enhance antigen processing and presentation, as well as T and B cell responses compared to RT alone, but that is under active investigation. We think there's a major opportunity to enhance therapeutic efficacy, as well as de-escalate surgery. So we've, again, as an anecdote, especially in our second phase 2 trial, which is underway, we've already been able to eliminate free flaps in a number of our patients that would have normally gotten it. And then we think based upon this, there's a major opportunity to improve quality of life outcomes in both HPV positive and HPV negative. But it's going to require really a paradigm shift in how we think about this disease and how we think about approaching. So I'll finish there, and thank you very much again for the invitation.
Thank you, Brian. Joe, do we have some questions?
I think Dr. Yam had a question. I don't know. Can we unmute her? Can we? Well, there are a few questions in the chat then. From Dr. Garg, what is the extent of resection post NACT according to the new or old scans, as the tumor does not shrink concentrically?
Yeah, that's a great question. The short answer is we treat to the we treat to the clinical margins of what is apparent at the time of surgery, not to the original margins. So for some patients, that may be little more than a big biopsy. For others, it may be substantially more than a negative specimen may dictate. So as I mentioned, many of these patients have a major pathologic or complete pathologic response, but we're treating to the clinically apparent regression bed. Sometimes that looks like not much more than a big ulcer that you might expect with radiation.
All right. Barry, Anna, should we move on to the next one?
The other thing that's important to realize though with these patients is we are interrogating the neck as well. So whether or not the neck or the gross tumor in the neck receives radiation, all of these patients are getting neck dissection as well.
Okay, yeah, Joe, I think we do need to move on to Dr. Wise-Draper.
Okay, thanks for having me. I'm going to be discussing brachytherapy and immunotherapy. So just one disclosure, I am a medical oncologist. So some of the questions I may need some help from our panel. So here are my disclosures. So just to discuss salvage surgery, so in recurrent head and neck cancer, we know that resection alone has a poor median disease-free survival of approximately about 20 months, depending on which study is reviewed. But if you add immunotherapy combined with resection in the adjuvant setting for these recurrent patients, there has been a potent and durable anti-tumor activity in head and neck cancer. So I first just want to discuss some of the immunotherapy studies in the adjuvant setting. This is just one led by our group as well as Carmano's using nivolumab after salvage surgery, where patients underwent salvage surgical resection and then received nivolumab for 6 doses. 39 patients were enrolled in this study between University and Carmano's Cancer Center. And what was interesting was that nivolumab did increase disease-free survival even in this recurrent setting. So up until this point, we've talked mostly about the upfront naive setting, but in these patients, there was also an increased disease-free survival, at least compared to historical controls from our own center, so that they were a little bit better matched than, even though this was not a randomized study. So 2 years disease-free survival was about 71%, and these patients compared to 41% in our historical controls. And overall survival also seemed to be prolonged, although it was not significant. Using biomarkers, PD-L1 was not significant between those that had an increased disease-free survival versus those that did not. However, using tumor mutational burden of greater than 10 or equal to 10, there was an increase in disease-free survival, although it did not quite reach statistical significance due to low numbers. So suggesting that TMB may be a useful biomarker, at least in this recurrent setting, using immunotherapy after salvage surgery. So we wanted to ask, what about adding brachytherapy? So rather than using standard radiation techniques, introducing IBT in combination with immunotherapy. So IBT alone allows for a high dose in a target region, especially in those where we have surrounding critical structures. So being able to give a high dose of radiation directly in that area. It's been studied in those with local regional relapses and has been shown to be safe, as well as improve outcomes. And I just show a couple studies here showing that there was a 2-year regional control rate of about 67%, and overall 1-year and 2-year survival rates of about 82 and 57% respectively, using this review. Other studies have also shown good local control and disease-free survival of about 45% at 1 year. So cesium-131 brachytherapy is a low-energy gamma isotope contained in a titanium capsule. Half-life is about 9.7 days, so patients are going to be relatively safe after they have the surgery due to decay. There was a study done recently by Lukenbold at Thomas Jefferson, and also included a couple other sites, including Case Western as well as University of Cincinnati, showed that there was good local control, so 49% 2-year disease-free survival. But interestingly, 31% of them had metastatic disease with a 31% overall survival rate. So suggesting that although local control was achieved, these patients still had a high metastatic rate, suggesting that combining IVT with a different type of systemic therapy may be able to control tumors much better. This is just a picture showing this mesh. So this is cesium-131 mesh being used in a patient with localized neck disease. And then you can see on the scanning where this mesh was placed. So the rationale for combination of IVT and PD-1 blockade was that as discussed by Brian Bell, radiation therapy has been shown to have multiple effects, but it's also been shown to increase PD-L1 expression on tumor cells, which may actually act as a resistance mechanism to radiation therapy. Cesium-131 alone, as I mentioned, improved local control, but not so much metastatic control, which may impact overall survival. IVT and immunotherapy has been shown to have some success in other tumor types such as hepatic cellular carcinoma and other tumors as well. So we thought that pembrolizumab prior to surgery, you would be able to prime and activate T cells. And then if you're able to continue after salvage surgery, as well as implantation of the cesium-131 seeds, that it would be safe given that these therapies do not have overlapping toxicities of single agents, and at the same time result in enhanced progression-free survival in patients with locally recurrent head and neck squamous cell carcinoma. That led to the study that is ongoing right now. So this is a study that is being performed here at University of Cincinnati, as well as Thomas Jefferson University, and Case Western is also going to join in. So far, 8 out of 51 patients have been enrolled. So in this study, patients are screened up front for recurrent disease, and as long as they don't have metastatic disease or easily controllable disease, I should say, they are eligible. They undergo 1 dose of pembrolizumab neoadjuvantly, so similar to the window of opportunity studies that were already discussed. They get this 1 dose day -14. They go on to get resection, and cesium-131 seeds are placed. And then after they've recovered from surgery, they receive 6 months of pembrolizumab every 3 weeks, although we have modified to allow every 6 weeks at 400 milligrams as well. So these patients will be followed for 24 months, safety being one of the primary endpoints, as well as disease-free survival and overall survival and local regional control. So our hope is that to be able to improve in this recurrent setting as well, similar to the upfront setting, that by adding radiation and immunotherapy techniques, that in this group that we will be able to control the radiation to that locally recurrent disease, and at the same time control any metastatic recurrence. So more data to come as the study enrolls, and that is all I have. Hopefully I would caught us up a little bit, and just to acknowledge everyone that's involved.
Thank you, Trisha. Joe, do we have any activity?
There were a few questions, but I think Dr. Lai does have time restrictions. So if we could maybe move on and come back to the questions at the end, that would be great.
Sure.
Joe, It's fine, Joe. Just go in the order you're going.
Okay. Who's next?
So we're going to continue on with Dr. Siparam to discuss cutting edge of correlative biomarkers and studies.
All right, can everyone see my screen?
Yes.
Okay,
Yes.
great. All right. So, first of all, thank you to the organizers for inviting me, Joe, Barry, and Anna for kind of leading this effort. I'm going to focus my time very briefly here. I'm thinking about what are the really cutting edge correlative biomarkers we need to focus on in our studies. And I think Bob nicely laid out the fact that we can't really do these studies without biomarkers, because that's really going to be not only how we learn about which paradigms are working, but also work on stratifying patients. So I think it has benefits in multiple different ways. And in an ideal world, some of these biomarkers may even inform future studies in terms of additional combination therapies. So when we talk about biomarkers for these trials, we really have to think about this in a very broad sense. And we can think about this in a multifactorial fashion, not only thinking about patient samples for correlative studies as was outlined by my colleagues, but also thinking about how we can use different analytical platforms to then help inform in vitro modeling and in vivo modeling. And certainly an important component of future studies is actually going to be able to take pieces of these on-treatment samples and pre-treatment samples and actually develop models at scale. The development of patient-derived xenografts and organoids is a rapidly advancing and important area of our field. But I won't focus on that today, and instead I'll focus on patient samples for correlative studies, as that will likely be of greater interest to the individuals on this seminar. So when we talk about tumor biopsies, these are really going to be the gold standard, the idea being that we can actually obtain tissue from the patient to understand what's going on within the tumor. Problem with these is they're invasive, and depending on the study, if we're talking about salvage surgery or in the recurrent metastatic setting, it can be challenging to convince patients to get an on-treatment biopsy. I think it behooves us all to really establish this as a paradigm for our trials in order to enable us to really make progress in the future. But in parallel is this evolving field of liquid biopsies being pushed by a number of colleagues in head and neck. And these are really non-invasive methods that look at cell-free DNA, circulating tumor cells, and other methods. There's really a lack of standardization here, and certainly that represents a challenge. But at the same time, because these are done as liquid biopsies, they can be done throughout treatment. And so this represents an alternate paradigm that's important to explore, but won't be the focus of the talk today. So I'm going to focus almost exclusively on tumor biopsies, just in the interest of keeping this talk somewhat narrow. We all know that there's been a wave of sort of genomic studies in head and neck cancer, ranging back all the way to the early 2000s, that defined the mutational landscape of tumors, the expression state of tumors, and these are some of the seminary papers in our field. But we also know that tumors are heterogeneous. Work from Jim Rocco, as well as others, has emphasized the fact that tumors exist in heterogeneous states. We know that tumors are not a homogeneous ball of cells. And we know that when tumors are heterogeneous, as defined by a score that Jim defined called MATH, these patients have worse outcomes. This is true whether you look at HPV positive tumors or HPV negative tumors, as shown in the lower right. So how do we get beyond this bulk approach? Well, just to sort of take a second and break it down so it's really, really digestible for folks, we could think of a tumor as somewhat of a fruit salad, different components that contribute to this complex ecosystem. And when we do bulk sequencing, we take a piece of that tumor, we grind it up, and you end up with a smoothie. And if you taste it, you can have different flavors in the smoothie that you kind of get a hint of: strawberry, banana, orange. You don't actually know the proportions of those. You don't know how that ecosystem is interacting in a complex fashion. And something that Bob introduces is the concept of single cell sequencing. We can now take a tumor, separate it out into individual cells, and then sequence this. And this is something that my group, as well as Bob's and numerous others, is pushing forward to sort of better understand what's going on when we look at these clinical trial biological correlatives. And as he showed you, we can take a tumor, and using a droplet-based approach, he had a fancy animation and to kind of demonstrate how this works, we can separate cells into these oil water-based emulsions and then analyze each cell after it's been barcoded and then pooled together. And that's how we can go from a complex tissue to taking advantage of this single cell approach. So what does this really give us? Well, the advantage of these types of correlatives, which are really the cutting edge that I think is where we're going to go in the future with patients, is that it not only allows us to define the diverse non-malignant cells that are present, different T cells, endothelial cells, fibroblasts, macrophages, These are the things that Bob focused on, but also diverse functional and genetic malignant cell states. Those are actual malignant cells that are doing different things, whether it's driving proliferation, driving metastasis, driving recurrence. And it's these subpopulations that drive some of these recalcitrant phenotypes that all of us struggle with our patients and within the field. We can also think about how these different cells interact. So when we start to think about these complex technologies, of course, there's a lot of challenges that arise when we think about these new age and cutting edge correlatives. And I outlined here a couple of things that I think that all of us, when we think about clinical trials, need to keep in mind. The first is careful planning and coordination before, during, and after the trial. Many of these samples need to be processed or sorted almost immediately, and there needs to be a consistent coordination of that sample collection, a robust analytical pipeline to avoid batch effects, which will completely throw the results sort of out the window. The second is cost. Some of the methods I outlined to you, while they sound exciting, they certainly are. They typically cost about 1.5 to 2K per sample. And so that's if you're talking about a pre-treatment sample and an on-treatment sample, or even a third biopsy, this can get expensive quickly. Yet there is a real need for this data and a need for this multi-omic, both single cell, also epigenomic and other types of data. Finally, it's important when designing a trial to think about tissue preservation. Are we going to use fixed tissue from the tumor resection specimen, which has limitations, frozen tissue, which may allow us to do bulk approaches, but may be harder for single cell, or just take a fresh approach where we're sorting? Generally, we're going to favor approaches that allow for batch processing, that is perhaps sorting the cells and freezing them, as Bob alluded to, or having a consistent person processing these samples. The issue, though, is that while it's exciting to think about single cell sequencing and other type of translational biomarkers, as we think of this top part of this picture, it not only involves a pretty lengthy timeline to analysis, around 3 weeks for most places in the country right now, but also requires significant analytical and computational work. So we really need to also think about how can we take these different biological approaches and biological correlatives and then break them down into something that can be applied in a regular pathology lab with immunohistochemical staining or other sort of standard approaches. And in that regards, adjusting the way we think about frozen margin workflow or even permanent pathologic analysis requires thinking about spatial analysis in order to make progress. So if we go back to the analogy I set up in your mind, where we think about bulk as being the ground up specimen, single cell being each individual component of the fruit salad, we can also think about maintaining the spatial information. That is, where did these cells come from and how can we use that to better understand? Now, one advantage of this approach is it's often at this point being performed on frozen sections or FFPE, which allows you to do this analysis on a much, much smaller piece of tissue than you would if you're trying to extract individual single cells and analyze them. So I think this is very much where the future of our field is headed. And I just kind of want to show you, before I jump in, and briefly show you where I think we can get some additional correlatives, kind of an overarching view of this, which is if we think of the primary tumor here in the middle, we can do bulk approaches, we can separate into individual cells here shown on the right and the bottom, or we can actually maintain spatial information with a variety of different techniques. So what does that really look like? Well, you know, we've been very interested in this invasive program that's at the leading edge of tumors, which is a hybrid epithelial mesenchymal program. We think this program is at the leading edge of tumors where it drives invasion and metastasis, as sort of outlined here in this model. And when we think about this, of course, then spatial information becomes important. If you think there's a unique localization of a certain population of cells, then simply biopsying the tumor in the middle or an area that doesn't have these regions may be challenging to utilize as a biological marker. And one approach takes advantage of basically something known as different platforms, have different names, codex, multispectral imaging, et cetera. These all use antibodies to look at different markers. And without getting into the details, I want to show you what you can get with this. You can basically get a section that's stained with anywhere from 8 to 50 different antibodies. And the advantage of this approach is you can use fixed tissue. You can look at up to 800,000 individual cells, and then you can start to break this up and actually look at individual markers and generate a composite image that's broken down into, you know, individual cells. And I'll show you how this works. We'll see how well the animation works.
Excuse me, Dr. Brom, can you wrap this up? Just Dr. Lai has time constraints. Thank you.
Sure. So we can break this into our individual components and take a look at these and actually then analyze the relationship of the different cells to each other, separating out tumor and stroma, and then actually analyzing in detail the spatial relationship of cells. So we can also look at how this relates to the immune system, giving us a detailed set of analyses of the complex ecosystem. So the other thing I just want to briefly end on is just showing you that you can actually take advantage of this to look at tissue at an individual neighborhood cell basis. And this is a technology called spatial transcriptomics, represents an alternative platform. So all of this to say that we need to really think about what these cutting edge biomarkers are as we try to think about trial design. And all of this will require then going back to specimens we have to get power of scale. So, I think I kind of covered the key conclusions. So I'll conclude in the interest of time and hand it over to Steve.
Thank you very much. Okay, the last discussion is by Dr. Stephen Lai on cooperative group trials.
Hey, I know we're at the top of the hour, so I'm going to kind of summarize very quickly a couple of key points. I was asked to talk about cooperative group trials. My goal here is to really encourage us all as surgeon scientists, as surgeons, to join these trials. The only way you're going to learn how to run a trial is actually to run a trial. And I think that's the most practical lesson that you can get from all of this. The other thing I would say is, I really enjoyed the talks about all the biomarkers and things like that. I think tumor specimens are absolutely critical. We need to get them. But I think there's also a lot to be learned from imaging-based quantitative biomarkers that move beyond RECIST criteria, that move beyond sort of anatomic criteria and glucose transport. So I think there's a lot in that space as well. What I wanted to show you is just kind of, trials where surgeons have been involved, where we have been able to have sort of iterative learning and sort of improvement of the processes that we do. I think Frank Savantos's trial back in 2010, when it published, the ACOSOG Z0360 trial was very important. It was a validation that we could do a multi-institutional phase 2 trial looking at sentinel lymph node biopsy here in the United States, and started us on a path to kind of develop that technology and that surgical procedure for early stage oral cavity cancer. It also told us a lot about surgeon credentialing, the need for surgeon education, and the fact that we as surgeons could lead these kinds of efforts. I think the ECOG 3311 study, definitely surgeon-led, looking at sort of radiation, sort of de-intensification in that field, also has continued to that with not only the advances with TORS, but has also taught us even more about how do we properly educate and how do we sort of assess quality of the surgeries that are being done by our surgeons in these large-scale trials. I think this is going to be coming up not only in the context, then have we started looking at sentinel lymph node biopsy for early stage oral cavity cancer, but we're starting to look at lymphatic mapping in lymphoscintigraphy for oral pharynx cancer, where I think it's just as important when we're talking about dose de-escalation that we are also potentially talking about volume de-escalation for these patients. And so I think there's a lot to be learned in that and a lot to be gained from the process of being involved in a study like AHN006 and also now John Day Almeida's HN11 out of the Canadian group, also to be run through NRG Oncology. I wanted to give people a context. We do these studies, we do these trials, we try to gain level 1 evidence. We look at the story of what happened with watchful waiting versus elective neck dissection for early stage oral cavity cancer, 4 decades or more of sort of debate and controversy and sort of underpowered studies to try to answer that question. And then DeCruz and his group out of Tata Memorial Hospital really kind of came to the fore and answered that question. Similarly, we're looking at early stage oral cavity cancer and sentinel lymph node biopsy. We see the ACOSOG study in 2010, NCCN guidelines that have now included sentinel lymph node biopsy, but for a number of sort of reasons, as sort of we get more adoption in Europe and Asia, it hasn't quite reached that sort of similar level here in the United States. The NRG HN006 opening in July of 2020 has gotten us now, at least I think, on the path to looking at really gaining definitive evidence. I think the French and the Japanese are to be applauded for their efforts in sort of their trials that they've executed, but I do think that there are fundamental issues with those trials themselves. So I just want to show you, if you want to start a trial, this is where you start. You know, you put it together, you bring it to a cooperative group like NRG Oncology, you find a surgical subcommittee that has people like Chris Holsinger and Eric Sturgis that are very supportive and sort of giving you feedback and helping you to develop these studies. You create multiple arms that are that require way too much power to actually be able to assess it. And over time, you develop a more simplified trial, but a trial that is actually well integrated into the cooperative group effort. And, you know, so like this trial now incorporates the PET CT scan and the learning, the prospective data and findings that we've learned from the ECOG Akron 6685 study. And so I show you all of this just to give you a sense of, you know, the time that is involved in sort of getting a trial to kind of fruition and into actual activation. I want to make sure that I thank all of the people, the co-chairs, the multidisciplinary approach to really putting these kinds of studies together, the effort that's required not only at the planning and execution of this, but also then at the individual sites with the individual surgeons and their teams as they're sort of putting these things together. And so I applaud the surgeons who have gotten involved. You know, there are seasoned surgeons in this list. There are also surgeons who never have run a trial before. I will tell you frankly, when our fellows leave this institution, I tell them, hey, get involved with the study. It doesn't have to be this study, but if you're going to learn how to do a trial, you just have to get involved. And so with that, I also want to say that as chair now of the Surgical Oncology Committee, this is also another learning opportunity. We're trying to get the guidelines out to the different tumor sites to look at how do you develop quality assurance working groups? What are synoptic reports, operative reports that we can put together to kind of help patients that are already in trials and helping the clinical research team to gather the data? What are, you know, we've talked a lot about surgical margins, but are there surgical margin lessons that we can learn from breast cancer, learn from colorectal cancer surgeons and sort of start incorporating in head and neck surgery? And then frankly, you know, we've mentioned this already, but surgery following neoadjuvant therapy. What are the guidelines that we're going to be able to use? How do we do that uniformly? What can we learn from the other studies that have been done? And with that, thank you very much.
Okay, I want to thank all of the panelists for great presentations tonight and for really some thought-provoking discussions. I want to thank all the attendees and Mania for organizing all of this tonight. I don't know if, Joe, if we have time. I know it's 7:03 for questions or not, if people want to stay on for a couple of questions.
Well, I mean, I think Monia said we had a few extra minutes, so I'm just going to read out some of the questions. I also just want to say thanks, Steve. I have to commend you. I remember when you first put that trial together, it's a very huge lift to get it through. Okay, so for the panelists, first question, do they, for the panelists, for those patients who have a complete response with neoadjuvant immunotherapy, number one, do they undergo any surgery or a quote unquote big biopsy? And number two, is an immunotherapy regimen continued? I believe that's afterwards. And number three, if so, for how long? Those are your questions.
Maybe I'll throw in a quick answer and let others chime in. They absolutely undergo standard of care therapy. There is no appropriate way to, at present, off of a clinical trial, to change your clinical management, no matter the response, from 2 doses of immunotherapy. So it's not safe for patients. We need to test it. It's a great idea, but we need to design a study where we have good endpoints. Do you tattoo the margin? How do you figure out, you know, what to do going forward? So natural question, good question. And at present, we've not designed a study with continued therapy. But I think the 689 has that, where the surgical specimen after neoadjuvant is classified as high risk or low risk, and then they're eligible for pembrolizumab with or without standard therapy, depending on what the specimen looks like after the neoadjuvant phase.
I just add on to that it depends on the protocol in terms of the number 3 part of your question is it, or number 2 and 3, which is immunotherapy regimen continued? It just depends on the protocol, and I think there are different approaches, but in general, most of them have some degree of adjuvant immunotherapy after all of standard of care, which involves surgery plus risk-adapted adjuvant therapy is indicated.
And I can just add for the studies that we were involved in, that after CR, that the immunotherapy was continued. So pembrolizumab was continued in the upfront studies for 3 months. With our trial, Radiotherapy also continued the pembrolizumab. And then with the nivolumab study, we actually didn't have any complete responses in the recurrent patient population, so that they all continued as well.
I do have one question, if that's okay for the, I guess, doctors Bell and Ferris. So when you get these great, major responses and downsizing of tumors, and you base your resection on the new imaging and clinical exam, take 1 to 2 centimeter margins, since we know tumors don't shrink concentrically, are you concerned about your local control rate? And how do you think that will be, if at all, affected over time?
I'll just comment briefly, and Brian is using a bit of a different approach because of the standard of care type modality of radiation. I guess one thing I would point out is, although we have for years said, that it doesn't shrink concentrically, that was due to chemotherapy, which stops once you stop infusing the drug. The immune system, and whether this is a little bit of a cell job or not, we call it in situ vaccination, but you do retain antigen specific cells, after the tumor resection. So there may be some durable benefit. But your question is a good one. I've so far not had a local recurrence in that situation as you described. The numbers we have here are relatively low, probably aggregate, 60, 80 patients.
And what's your follow-up so far, Dr. Ferris?
Well, from the cetuximab trial from 2008, we've got 10, 12 years. From the Checkmate 358 that we published about a year ago, we've got 3 years of data. And we weren't the only accruers. Memorial, Steve Powell and Chad Spanos at South Dakota, but we put a good number of patients on those trials. But PD-1 monotherapy is really not, I think, where this neoadjuvant is going to land. It's some sort of combination.
Lots of good results. Thank you.
I don't know if we can squeeze in one more question, but for Dr. Bell, I maybe you commented on this, but when you did the neck dissections after your trial, did you see evidence of pathologic response, or was there evidence of previous tumor in untreated or radiographic?
Sure, Joe. Yeah. So we have seen a number of cases where we found tumor regression in unradiated micro deposits or relatively small deposits of subclinical disease in the neck, because anything that's clinical, at least in our trial, got radiated. But clearly there is still an immune response that is generating tumor regression in other areas, and so we've seen a number of cases. Numbers aren't large because the number of patients aren't large, but we have had I think 3 maybe cases that I can think of where our pathologists demonstrated pretty convincing evidence of tumor regression in an unradiated metastatic deposit.
It'd be a great a source of information for some of Sid's correlatives. I think the codex there would be really awesome to kind of look and see what drove that response,
For sure.
All right, Barry or Anna?
I just want to apologize to Dr. Bell. I had some misinformation.
No worries.
I just wanted to say thank you to everyone. Hope you all enjoyed it.
All right.
Right.
I think
Thanks.
we're going to wrap up then.
Thank you so much.
Good night.
Thanks, everybody.
Thanks,
Have a good
everyone.
night. Thank you. Thank you.